Can everybody hear me? Okay, a very warm welcome from myself, Marika, to each and every one of you taking the time out to join us this evening. For those who have previously joined our webinars, we would like to thank you for joining us once again and for your support. If this is your first webinar with us, then I would like to say welcome, sit back, relax and enjoy a very informative, well-prepared evening of topics that will really interest and benefit you in your practice and perhaps answer some valid and relevant questions you might have in this current new COVID abnormal era and challenges we are faced with. We are doing things a little bit different this evening. We've put together an excellent expert panel comprising of very advanced medical professional specialist backgrounds that will be presenting and discussing very few relevant topics. So just before we get started and I hand over to our speakers, just a few logistics to navigate you around the platform to be able to participate actively in our question and answer sessions. So to keep things professional, concise and focused as possible, we have muted all attendees. Therefore, you will only be able to utilize the chat box when we indicate to do so, but you won't be able to unmute yourself or talk at all. So without further ado, I would like to introduce to you our first speaker, Prof. Eftia Vardas, a clinical virologist and partner of the Lancet Laboratory Group. Prof. Vardas completed her undergrad studies at the Wits University, obtaining her degree in Bachelor of Medicine and Surgery, as well as Bachelor of Science degree with honors. She completed her postgraduate studies, obtaining her professional diploma in tropical medicine and hygiene and diploma in public health. Her specialist training was done at the National Institute of Communicable Diseases and her fellowship in clinical pathology from the South African College of Pathologists. Her work in clinical virology the past 20 years has focused on the control of important human viral infections, and she has conducted clinical trials phases 1, 2, and 3 in hepatitis B, HIV vaccines, and microbicides and HPV vaccines. She is an honorary extraordinary professor in medical virology at the Faculty of Health Sciences, Stellenbosch University, and the head of virology at Lancet Laboratories. She also served on the COVID-19 Ministerial Advisory Committee to the Minister of Health from March to September 2020. So Prof. Vardas, we welcome you, and I hand over to you to start with your presentation. Thank you.
Thanks very much, Marika, and thanks to everyone for being here this evening. I think it's a very nice group of people speaking, and it's a long program, so we'll try and just jump straight in. So when I was asked to do this presentation, I thought it through and thought, well, where is the intersection of COVID with allergies and asthma? And really, there are three main areas in the diagnosis of COVID and allergies and allergic rhinitis, in the disease and in prevention. So I'm going to touch on those topics, each of those topics. The biggest part is the interaction of COVID and allergic diseases and asthma. So that's the biggest part of the talk, a little bit on the diagnosis and a little bit on the final part of prevention. So here's the virus that changed our lives. You're all familiar with it. This is SARS-CoV-2. It is a beta coronavirus, which is probably a zoonotic entrant to humans in December 2019. It jumped from bats to an intermediate host, most likely the pangolin, which is still up in the air. But this is the culprit. And the important thing about this culprit is that it has a very common structure to coronaviruses, these little spikes that stick out, which make up the sort of crown of the coronaviruses. From our point of view as virologists, the spikes are very important. So the spike, this so-called S protein spike, and I'm not sure I can actually activate my marker, so please forgive me. This S protein spike is the bit of the virus that connects up with the human cell through the ACE2 inhibitor, so very important. Then you have the other structural proteins, the envelope and the membrane and the nucleocapsid. The nucleocapsid is important for us because we use that in diagnostic tests, and it's the most abundant viral protein that's produced, and so we pick that up with ELISA tests. But each of the structural proteins are picked up in various tests that we use, PCR tests and antigen tests as well, so very important in that point of view. The spike protein is where the variants also occur. Changes or mutations in the spike give rise to the variants. So the genome is in panel B is sort of there's a linear sort of picture of the genome. It's not really linear. It's all mushed up as an RNA bit in the center of the virus. But it is important that there's various open reading frames which are non-structural proteins, and then the structural proteins all at one end. Very, very similar to the bat virus, about 80% similarity to the bat virus. The one thing that is really important about this slide is these were the symptoms that have been associated with infection with SARS-CoV-2 or COVID disease. And if you look at them, they're very non-specific. People get fever, fatigue, loss of smell is actually more specific, and I'm sure the ENTs on this meeting are going to touch upon the mechanisms and how this works. So that is more specific, but the rest of them are really just symptoms that indicate a viremia. We have myalgias, anorexia, fever and fatigue. Once this virus gets into the lower respiratory tract, you can get lower respiratory symptoms, which is dyspnea and sputum loss, but very non-specific, as we all know, symptoms. So difficult to actually place. So the first interaction of COVID and allergies is here. So with COVID, you've got specific symptoms. With allergies, you've got specific symptoms. But when it gets really confusing is the overlap of both. So both of them can present with cough, fatigue, headache, sore throat, congestion or runny nose, and shortness of breath. Luckily, we've got better at actually diagnosing COVID, and we have very quick tests that we can do in symptomatic patients, like antigen tests. And so people presenting with this nebulous interaction of symptoms, which we don't know if they belong to either COVID or allergies, we can use diagnostic tests to actually tease out that process. If we move to the next section, is how COVID and allergic rhinitis interact to cause disease. We are all familiar with the fact that co-exposure to certain pollens may increase susceptibility to viral infections. And this is very interesting work that has occurred. So it really has shown that regardless of your allergy status, this exposure to the pollens may increase susceptibility to respiratory viral infections. There is a relationship with humidity, temperature, and certainly with people and the population density, or the density of people in a group. And this has been shown to be affected by lockdowns. What is this mechanism? How does exposure to certain pollens make you more susceptible to viral infections? Well, it has been shown that pollens decrease gamma interferons in respiratory epithelial cells, and this increases your susceptibility to rhinovirus. And this occurs because you have an increase in the interferon 1 beta and certain other interferons which activate the so-called inflammasomes. What does COVID do? COVID has these open reading frames, remember those non-structural proteins, as well as some of the structural proteins, the nucleocapsid and the M, that actually also decrease interferons. So that's an interesting mechanism. It uses this mechanism as a viral escape mechanism, but also that now increases susceptibility to infection. It also has certain bits of its genetic material that activate the inflammasome, which starts a whole process of pyroptosis, which is a programmed cell death associated with with an infection, and starts a process of an IL-1 beta storm, which eventually leads to multi-organ failure. Sorry about the slide. There's a typo on that slide. This is a very simplified point of view, but really just to make the point that exposure to pollens may increase your exposure to respiratory viruses, and particularly SARS-CoV-2. What we became very familiar with quite quickly with SARS-CoV-2 infection and disease was that the vast majority of cases, 81% of cases, were very mild, and that was the good news. The bad news, there were two bits of bad news, and the bad news is that certain people went on to develop severe disease, and another proportion of people, about 5%, developed critical disease. Comorbidities were associated with that, higher age, Men got more severe disease than women. High BMI, diabetes mellitus, hypertension, coronary heart disease, as well as chronic kidney disease. And bunged into that was also chronic respiratory disease. The second part of bad news was that we found out, if you look at the bottom of the slide, there's a very sort of nice grey area. Unfortunately, we found out that there were a whole bunch of asymptomatic people were infected asymptomatically, which obviously increases the survival potential of this virus. And so it was being transmitted by asymptomatic individuals, and it is a really big problem, our Achilles heel, as we call it, for SARS-CoV-2. So at the very beginning of the COVID pandemic, people were saying, well, chronic respiratory diseases must be a risk factor, and asthma is a chronic respiratory disease, and so therefore it falls into the same grouping. So a lot of public health agencies came out, WHO, CDC, all came out saying, well, it's a chronic respiratory disease, so it must increase your vulnerability to severe disease and also perhaps to infection. We know that asthmatics are vulnerable to viral respiratory infections, and that asthmatics get exacerbations. Excuse me, I think that I'm on call as well, so my computer's doing all sorts of things. Exacerbations caused by influenza, rhinovirus, and even other human coronaviruses. And so it seemed to make logical sense that SARS-CoV-2 would also cause more severe disease and worse outcomes. The other big controversial issue that started to be discussed was, well, asthmatics and people with allergic rhinitis are taking inhaled steroids. Maybe that will, this is immunosuppressive therapy, maybe that will increase their risks to SARS-CoV-2 infection, as well as other immune modulating drugs that people with asthma and or allergic rhinitis might take. For example, anti-IgE monoclonal antibodies, which deplete eosinophils, and would this increase risks? And it's actually quite interesting that that depleting the eosinophils may increase your risks to SARS-CoV-2 infections. So people started to do studies, and here's a study from Chiba et al. Published in JACI in June of 2020, so very soon after the global pandemic. And what they were trying to see was, well, they looked at people in the US and people that had been admitted for a period of time, I think it was about 4 months, in hospitals in the Chicago region of the US. And they said, okay, so here's a whole bunch of people that were admitted who had asthma, who had a diagnosis of asthma. And they isolated out of the 1,500 odd people, about 200 people that had a diagnosis of asthma. And then they looked at those people to see what proportion of those people did worse and what treatments they were on. In this cohort, which is quite a big cohort, 53% of them were female. They were aged mainly between 40 to 69 years of age. And of the entire cohort, not just the asthmatic cohort, about 55% of them were hospitalized. And there was a mortality overall, about 5% mortality. The second panel of this slide shows you really the percentage of COVID patients that in the asthmatic group, in the dark bar, or in the non-asthmatic, sorry, the other way around, non-asthmatic group in the dark bar, and in the asthmatic group, the see-through bar, how many of them had these so-called comorbidities. And you can certainly see with obesity, hypertension, obstructive sleep apnea, that is what OSA stands for, COPD and GERD, that more asthmatics had more asthmatics had COVID in those groupings. The diabetes was more or less the same, and the coronary artery disease was more or less the same as well. So there was this sort of indication that the comorbidities were actually increasing your susceptibility in the asthmatic groups. What they then did is they did these models to try and show whether or not there was an increase in susceptibility and an increase in the severity to the infection if you had asthma. So in the top table 2, they adjusted for age, sex, race, and ethnicity, and they compared the asthmatics versus the non-asthmatics, and there was no significant difference between those people with those adjustments. they went another step forward and they said, okay, well, we had this more or less different percentage of people with risk factors in the asthmatic group versus the non-asthmatics, but can we account for it, or are these confounders? And they actually showed no significant differences again. They then looked at the various treatments that these people were on, and looked at their hospital admissions, and again there was no significant difference. So in fact, it showed really that there was a there were more confounders in that first graph than anything else. And if you looked at the actual models, there was very little to show that. People carried on looking, and this is a very big study, which was done in Korea, and they looked at the entire cohort of nationwide of all the Koreans that were diagnosed with SARS-CoV-2 between January the 1st and May the 15th of 2020. And they divided them up into people with COVID and asthma, with COVID and allergic rhinitis and atopic dermatitis. And they looked at the various outcomes and the severity of the outcomes of those patients. And in this study, which was massive, lots and lots of patients, they actually, and this is where this is the results of the study, and you're looking really at the odds ratio in the central sort of dark panel here, and the ones that are pushed onto the right-hand side of the slide means that there's a slightly increased risk. But if you look at the odds ratios are not remarkable. So there's not a remarkable increase in risk, except for one thing. And this is, I need to draw your attention to. There is a remarkable increase in severity with non-allergic asthma. Not allergic asthma, which is the one above the red ring thing, which is 1.4, but it's a 4 times increased risk of severity with non-allergic asthma. So this was a bit of people were a bit confused. More work has come out, and the most recent abstract is this from Eggart and all from the Allergy Association meeting in the US in February this year. And basically, they've done a big multivariate analysis, and they've adjusted for all of the confounders, and they're showing very clearly that mortality and hospitalization is not higher in asthmatics. And there is no significant association between asthma and COVID hospitalization. They showed in this study that these are the confounders here. The important thing that they did point out is that is different for people that have uncontrolled asthma. And people with uncontrolled increased risk, people with controlled asthma are as normal people. During lockdown and times when it was difficult to control. Quickly, the data on children is very rare and very little. We all know that there are lower case fatality rates with COVID in children. And most studies, if you look at all the studies, a big study by Papadopoulos and his group showed that if asthma control is good, there is really very little difference with kids, and they should not be kept back from school. There was this whole thing in much of the literature discussing about kids with asthma going back to schools. Obviously, they need to continue asthma medications and remain controlled. An important, let's go back to virology, because that's what I like talking about. An important thing that we need to think about is this S spike protein and the ACE inhibitor interaction. The invasion of cells is initiated by the spike protein binding to the ACE inhibitor, and the spike protein is then cleaved into 2 different subunits, S1 and S2, by the cell proteases. This S1 binds to the ACE inhibitor, and there is this transmembrane protease serum that also is important for the actual thing to occur, for the fusion to occur. So the fusion and the release of the virion into the actual cell is critically important. Now, why I'm going on about this is that it has been shown that Th2 inflammation, which is what we find in allergy and asthma, downregulates ACE2 receptors, and that gives us a protective effect, in fact, of these conditions with SARS-CoV-2 infection. There is a very nice long seminar in immunology where they show that eosinophils, in fact, also mitigate the risks with SARS-CoV-2 infection. And so allergic asthma is certainly is protected. People with allergic asthma are protected, and that's what the Korean study showed as well. And the big studies and the multi analyses are showing that lower mortality rates occur in multiple studies and smaller case studies as well. So that's very interesting. There is a protective effect. Now, the last two slides before we go to questions are on COVID vaccines and how they interact with asthma and allergic rhinitis. We are all very familiar with this pack of vaccines that we have available to us in the world at the moment. Not in South Africa so much, but certainly in the world. And one of the most remarkable things of what we've done in this pandemic is how quickly we've made vaccines and how many vaccines we've got. And each of them have got certain advantages and disadvantages. In South Africa, we only have the J&J and the Pfizer available to us. Hopefully we'll get access to some of the others, but there is a whole bunch. The mRNA vaccines are the ones that have showed the best responses with the best efficacy outcomes. Again, there's a bit of a confounder on how efficacy is measured in all of these things, but all of these vaccines are available and are pretty good. So if we consider them in the context of allergy and asthma, should we consider asthmatics and people with allergies in the risk prioritization and access to these vaccines? And certainly, if we think about it, uncontrolled asthmatics and non-allergic asthmatics would fall into a risk prioritization and should receive vaccine first. All other asthmatics and people with allergic rhinitis do not necessarily fall into a high-risk group. These vaccines are not contraindicated in people with allergies, even if they are severe allergies, and this is to every allergy. There are statements that have been put out by the Allergy Association of Allergy Foundation of South Africa, as well as ALSA, and it's very clear that no matter how severe your allergies are and to what you've got, it's not contraindicated to the COVID vaccinations. People on desensitization vaccines, SLIT or SCIT, also it's not a contraindication. So what are the contraindications to COVID vaccines? There are very few. One is anaphylaxis. Now, anaphylaxis to vaccines occurs very rarely, about 1.3 in every 1 million doses that have been given. If we look at the mRNA vaccines that both contain polyethylene glycol or PEG, there is a slight increase in the anaphylactic reactions that occur with these vaccines. With Pfizer, 5 per million doses that have been given, and with Moderna, 2.5 per million doses given. So if you compare that to the population prevalence of anaphylaxis, there is certainly an increase with these vaccines, and it has been put at the door of the PEG. Most of these reactions occur immediately and within 4 hours of the vaccine dose. Another contraindication to vaccination is reactions to previous vaccinations, either the first dose of your COVID vaccine for people that are receiving multi-doses or people that have had serious reactions to influenza. And we're not talking about minor local reactions, we're talking about people that get ADEM and other serious conditions after vaccination. And so that you need to do in consultation with specialists. And finally, people with mast cell disorders that have measurable raised mast cell tryptase. And I believe we're going to go to the questions now. Prof. Maharaj, I hand over to you. I haven't seen the questions yet, so I will just stop sharing my screen and then come back to you. There you go.
Good evening to everyone. Thank you for a wonderful presentation, Professor Vardis. So the first question we have is from Tamlin, and what she'd like to know is she mentions that using the antigen test to differentiate between simple allergies, upper respiratory tract infections and COVID-19, we are seeing a large number of patients with these symptoms this season, and it would be useful to know if this is accurate enough or whether there are too many false negatives to rely on it?
Thank you. That's a very good question. So in symptomatic patients, these tests are excellent. And I really would suggest, sorry, I'm going to switch on my camera as well. They're excellent tests in symptomatic patients, and certainly they should be used more frequently. Where they do suffer from false negatives is in asymptomatic patients. So I think that that's where they need to be used with caution. But I would highly recommend them in trying to distinguish between allergy and COVID symptoms. I think that they are good tests.
And just an expansion on that, Prof. Are there any clinical markers or clinical signs and symptoms that one could use to differentiate between allergic rhinitis and COVID?
Well, I think the loss of smell is very specific for COVID, but it also occurs with allergic rhinitis. But I think I'm a little bit out of my depth, and I'm going to leave that to the ENTs to answer. And I'm sure you guys are going to address that in your talks. But yeah, the symptom complexes are very non-specific, and that is our big problem. And that's why we have fallen back on laboratory testing in the main for making a real diagnosis with these things.
Okay, and in terms of the COVID-19 pandemic and other viruses, are there any other telltale signs that we would pick up in terms of the antigen testing?
I'm not sure I understand, Prof, but I think what the biggest impact has been of the COVID pandemic on other viruses is that we've been very good at controlling them. So all the non-pharmaceutical interventions of wearing masks and washing your hands and social distancing have been very good at controlling viruses like influenza. We will all realize, and I think we all know, that we haven't seen much influenza last year. So far, we haven't, touch wood, seen much influenza as well. We have seen, interestingly, at least with Lancet statistics, we have seen an increase in rhinovirus and RSV, which shouldn't be occurring if we all are sticking to our non-pharmaceutical interventions. I'm not sure I've answered the question, or if I understood the question correctly. I'm sorry about that.
No, you have answered the question correctly. I was just finding out because the coronavirus, well, this COVID-19 is a new virus, so its interaction with other viruses, would it aggravate asthma and allergic rhinitis? That was basically what I was trying to ask, and see if there were any other tests that one could do. But as you correctly mentioned, what we've seen is a suppression of the other viruses. So a host presenting with coronavirus and other viruses is not something that is very common. Am I correct in making that statement?
I think you're quite correct. Yeah, you're quite right. We haven't seen much of that.
I think that was a wonderful presentation, and we'll have more questions for you at the end. But Marika, I think we can now move on to the next speaker. Thank you to Professor Vardas.
Thanks, Prof. Maharaj. Thanks, Prof. Vardas. Yes, we will move on to our second presenter and expert panelist for this evening, specialist physician and ICU intensivist, Dr. Shahista Khan. Dr. Khan obtained her undergrad Bachelor of Medicine degree with honors from the Wits University, also completing her Master of Science degree in Clinical Epidemiology and Clinical Trials with her major in Biostatistics from the University of Pretoria. She specialized in internal medicine, passing her exams after just 3 years to become one of the earliest completers. She obtained her postgraduate master's degree in medicine from the University of Pretoria and now runs a very successful and one of the fastest growing physician practices in Krugersdorp. So welcome, Dr. Khan. We now hand over to you for your presentation. Thanks.
I'm struggling to unmute.
Dr. Khan, sorry if I can interrupt. It seems that you are still muted. We're going to try and unmute you. Sorry about that.
Can't unmute. Okay, I think it looks like I'm unmuted now. Can you guys hear me?
Yes, Dr. Khan, we can hear you. Thank you.
Thanks. Now it's taken away my ability to share my slides. Well, it's wonderful to be here with you this evening, and hopefully I'll shortly be able to share my slides. For some reason, the share tray closed.
Well, for what it's worth, you don't have any questions as yet, but I've got some questions for you at the end. So,
okay, there we go. Can you see my slides now? Okay. All right, so I've entitled my talk COVID-19 We Shall Overcome, because I do believe we're almost there, although we are headed probably 2 weeks away from what looks like a third wave. We are going to overcome this, and after the vaccination in the country, we should be able to recommence some little bit of normality, hopefully, in our lives. So all the information in the slide deck is valid as of the 11th of May, but please also refer to your current local guidelines after this, because things change almost on a daily basis. Due to the paucity of data, a lot of what I will share tonight is clinical experience based on what I've learned, especially with my mentors at Johannesburg General in the ICU. Okay, so around about the 5th of January 2020, there was a mysterious pneumonia outbreak. Dozens of people were sick in China. And on the 13th of January, this report came through that the Wuhan virus had appeared. At that point, that's what it was called, the Wuhan virus outside China, and the first human-to-human infection. On the 11th of February, it was officially named the coronavirus and COVID-19, according to the World Health Organization. And then by the 27th of February, we already had more new cases outside China than inside of China. And on the 5th of March 2020, we had the first reported case of coronavirus in South Africa, although we may have had cases prior to that, as we were not doing wide-scale testing at that point in time. Okay, so the coronavirus affects almost every organ in your body. The brain and the eyes and the nose has been discussed or will be discussed by other speakers tonight, and the heart and blood vessels and clotting as well will be discussed. I'm going to focus a little bit on the lungs today, and we're going to go a bit more in depth into lower respiratory tract effects of coronavirus. There is liver effects. Up to half of hospitalized patients have deranged liver enzymes. Some patients can go into a fulminant hepatitis as well. Kidneys, a lot of patients get acute kidney injury, whether this is due to a SIRS response or due to the virus itself or due to blood clots. There's many reasons for the kidneys being affected. And then the intestinal effects of this, a lot of patients report abdominal pain. When they come in, it may even be the presenting symptom. And a lot of patients, due to the use of steroids, and not being able to eat, not tasting, not smelling, etc. They do develop ulcers as well. We've had a few patients come in with GI bleeding. COVID-19, how does it affect the lungs? So there's a very busy slide which people can read at length. It's a wonderful slide to understanding exactly how the coronavirus affects the lungs. But once infected, what happens is there's this secretion of a proteinaceous, thick, insipid secretions which block off the alveolus, preventing it from opening well, and you begin to get mucus plugging. On this proteinaceous fluid, secondary bacterial infection starts to grow, and you develop pneumonia, a secondary bacterial pneumonia. And this has been a lot of the cases where patients are requiring ventilation and requiring high doses of antibiotics. Okay, so this is statistics from the 10th of May. And as we can see in Gauteng, in the last 14 days, there were about 6,000 cases. And previously, we had gotten down quite reasonable rates of cases. And what we can see now is that the case rate or the incidence is increasing again. And there's some very smart biostatisticians out there and people who basically predict once we reach a threshold as to whether we're going into a third wave. And apparently this level here is indicating a third wave in about 2 weeks' time. Okay, so the diagnosis, a lower respiratory tract sample would actually be preferred, but we don't do bronchoalveolar lavage on all patients unless it's required for other reasons. What we do is we do the nasal swabbing, and you can do oropharyngeal or nasopharyngeal, but nasopharyngeal swabbing is preferred. And I think most of us medical doctors who've been either exposed, have had this test and know how uncomfortable it is for patients. Okay, so how severe is the disease? About 81% of people should be able to be treated at home. About 14% may be able to be treatable in a clinic, and about 5% will require to go to hospital and be admitted. Okay, so looking at those scenarios with our country and our population, we were looking at treating about 640,000 cases in hospital, if we look at those numbers. But in South Africa, we only have about 6,000 ventilators. And this has become quite a problem. We noticed it during the first wave and the second wave, where we ran out of ventilators. And at some point, we had to make some very difficult decisions. In Gauteng, we had no ventilators available at any of the hospitals. And we had patients who still needed ventilation. We tried using transport ventilators. We even used the ventilators in theatre. And at the end, some difficult decisions had to be made as to who gets a ventilator and who doesn't. This sort of ethical dilemmas have been quite common with corona, especially because we have not been able to, or we don't have the information, and there's no precedent for us to set some of the decisions on. And there hasn't been a lot of medication. So maybe a whole different ethical talk is required on the ethics of what's gone on in corona. Mortality rates in Wuhan, it was about 2.3%. Globally, somewhere in some countries up to 5% mortality. In India at the moment, there's a lot of talk going on about the mortality, and I believe there was 2,000 deaths on one of the days. Considering the fact that they are having about 300,000 cases diagnosed per day, that's actually not as high a mortality as one could expect in such a country, with the level of care that's available, with the lack of oxygen, etc. So I know we're very, very worried about the new strain that may have landed in Durban on the ship that came through with people who are infected with the strain from India. But it looks like it's about having the same mortality to a standard or lesser mortality at present. Okay, this is just a picture to depict caregiver burden, because what happens when we go into a wave is that basically very few nurses are left over to care for a lot of patients. Extra beds are opened up. Patients that are taken in that are maybe requiring a higher level of care, with that decrease in available nursing. All nurses' holidays were cancelled. Also doctors, you know, especially in the public sector, have been really, really overworked, and it looks like we're going into that again. And that sort of emotional trauma for the health caregivers I think we can't underestimate what's going on out there. Just today, I was speaking to some of my colleagues, and we were discussing this third wave, and everyone's really, really stressed and anxious and not really emotionally feeling capable of going into this all over again and watching the devastation. So we hope that that third wave maybe doesn't come along. Please advise all of your patients and everyone you come across to sanitize and keep wearing their masks, keep social distancing, and try their best to stay away from contracting any of this. Okay. All right, so in the European Union, there's about 1 doctor per 279 patients and 1 nurse per 117. And in Africa, we have 1 doctor for 4,545 people, 1 nurse per 972. So you can just look at the fact that countries that are in the European Union are not coping with their burden of patients, let alone what would happen when we go into a third wave. Okay, this is a very interesting slide about contagious diseases, how contagious a disease is versus how deadly it is. So if you look at the coronavirus, it's somewhere in here. With its mortality versus the amount of contagious, not as contagious as measles and chickenpox, but those diseases have a much lower mortality than coronavirus did. Of course, we see Ebola up here, and I think HIV isn't projecting. HIV is somewhere here, and tuberculosis up there. Ah, there's HIV. Okay. So HIV eventually has a high mortality. And can infect quite a few people. Okay, so we already went through patients with existing conditions being at higher risk of mortality. Just to run through them again: cardiovascular disease, diabetes, chronic respiratory disease, high blood pressure, cancers, all increase the mortality, and of course age greater than 60 years old. And in South Africa, the wonderful problem that we have that gives us a double burden is retroviral disease and the high rate that we have of that. We have one of the highest prevalences, and only very little of these people are virally suppressed, which leads to people having a lower immune system, having to deal with the disease. That being said, interestingly enough, a lot of the damage that's done by coronavirus is autoimmune in flair and nature. So what I have seen is that some of the HIV patients actually do a bit better. Not those that are in the AIDS defining illness categories, but those with a decent CD4. Okay, and this is just a cute picture I saw of the prevention is better than the cure, and always with all diseases that is true. And then quickly to run through a little bit about the evidence for the medications that we're using. So obviously high dose vitamin D and vitamin C. It was found that there is lower levels of vitamin D in patients with coronavirus, and therefore the supplementation. I give about 50,000 international units once a week. And with vitamin C, I tend to give about 1 gram 3 times a day, so very high doses if they can tolerate it. Hydroxychloroquine and chloroquine were not found to be of any use, nor was lopinavir, ritonavir. At the moment, there's a lot of talk, or recently there was a lot of talk about ivermectin. At the moment, the FDA is still warning against the use and saying it can be dangerous. The studies conducted so far have shown no conclusive clinical benefit. It is being used in South Africa under Section 21, so it is available. And those of my colleagues that I've spoken to have not found a major difference. However, hopefully there'll be a few more clinical trials. Of course, steroids have been exceptionally brilliant, and that's how we know that there is some sort of autoimmune and immune basis to the disease. And basically, almost all, you actually have to find the patient, but you can't give the steroid. There was a decrease in 28-day mortality in the patients using dexamethasone. So if you can get a hold of dexamethasone, that is the one you'd use of choice. It's about 6 milligrams 3 times a day. You can get you can actually use that in outpatients as well. However, most of the people will still use prednisone for outpatients. About 1 milligram per kilogram a day should be used. And then tocilizumab, which is an antibody that blocks the IL-6 receptors. I've been using that in quite a few patients together with remdesivir, and it has been useful in the patients to decrease the risk of them having to be intubated if you use it at that point when the IL-6 is high and the patient is not yet requiring intubation. Generally, if a patient requires high flow oxygen for more than 4 hours, the patient is going to tire and will require intubation shortly. In those patients, we generally miss the boat if we're only starting the tocilizumab at that point. Okay, and then remdesivir, which for me has been quite helpful. I've used it in patients when they have to be admitted. And what I've found is since using remdesivir, I have intubated very few patients. I've treated over 600 patients with coronavirus now in hospital, between Joburg Gen's ICU and ICU at Krugersdorp Hospital. And around about November, December, we started to use remdesivir in the patients. And since then, I think I've intubated about 3 or 4 patients in total, whereas before that I was intubating sometimes 3 to 4 to 7 per day. So for me, it's made a great difference. And speaking to Prof. Mer about it, he says as well that if it's used early, that's when it makes a difference to the patients. Okay. So home care for your patients, basically any patient who can be treated at home should be, to decrease the burden on the hospital. Patients should be advised just to drink lots of fluids, eat, and actually they have to force themselves to eat because their appetite is quite low. They can have symptomatic treatment for their fever with paracetamol, and they should get a steroid. If they are requiring an antibiotic, which I normally recommend to my GPs that they do a CRP PCT on day 1. And if the patient is still stable, then again on day 3, day 1 being the day they first see you, day 3 being 2 days later. And if you see that is increasing, then probably the patient does need antibiotics. Okay, criteria for management at home. You need to have a SATs greater than 95%, respiratory rate less than 25, heart rate less than 120, temperature between 36 and 39, and a normal mental status. Then you can be considered as having mild disease and you can self-isolate at home. And other patients that are not at high risk of deterioration are those less than 50 years with no comorbid diseases such as cancer, hypertension, diabetes. Those, remember, we discussed increased rates of mortality and therefore should probably be treated at a higher level of care. Oxygen is probably the single most effective measure that we've had. And we know at some point during the last wave, there wasn't even enough oxygen available in KwaZulu-Natal to see patients. And at some point in Gauteng, I know our hospital was running at 90% use of our oxygen. So we were very close to, exceeding the rate of oxygen that we could actually supply to the patients. So you want to keep the SATs at above about 92%. After oxygen via nasal prongs or a face mask, a lot of people try rebreathers. I believe by the point you require a rebreather, you're probably going to tire very shortly. We then try implementing high flow or OptiFlow via the nasal cannula. But as I said, within 4 hours, if that's not working to stabilize your patient, you should move to early controlled intubation rather than intubating, under the stressful situation of an emergency. A lot of the patients, when you do that, they tend to decompensate from a cardiovascular point of view, and then you end up resuscitating the patient. And a lot of the times you can't actually bring the patient back because of those microemboli. The heart is not functioning that well. Okay, then a little bit about vaccination. There's a whole lot of clinical trials in progress. There's a lot of them that are in phase 4 at the moment. The timeline to complete vaccination in South Africa probably is going to be around about 2022. We would have hoped that by the 4th quarter of this year, we'd have everyone vaccinated, but that looks like it's probably not going to happen. And that's also based on the fact that a lot of people are not registering for the vaccine. Okay, and the vaccine that we're going to have available, Prof's gone through it, so I'm just going to quickly just run through. The mRNA vaccine from Pfizer should be available in the next couple of days to couple of weeks. 2 shots 21 days apart in the upper arm, and evidence shows 95% effective in preventing lab-controlled COVID-19 without evidence of previous infection. And then the J&J vaccine that I think all the medical people have been able to get their hands on by now, because we'll probably be very shortly stopping that trial. It's a viral vector. It's one shot in the upper arm. 66.3% effective in clinical trials at preventing the lab-controlled confirmed COVID-19. There are tests going on in a second dose that will probably increase efficacy. So the second dose will probably also be 2 weeks after if that trial comes out and shows increased efficacy. And it also prevented patients from being hospitalized. And I think that's pretty important because we're not going to cure corona the way we did smallpox. Corona is going to still be around in some way or form, probably with a seasonal burst that occurs with some sort of mutation for a while. And if we can prevent hospitalization, if we can prevent morbidity and mortality from the disease, then I think then that is a win that we've gotten already there. So there was an increase in asymptomatic infections, so patients that become infected are more asymptomatic. This is a little bit of an issue because if you're asymptomatic, it means you don't isolate, which means you can then spread the disease if you have asymptomatic infection because you wouldn't know to isolate. However, the decrease in hospitalization, I think, is the big win here. Okay, and then obviously it's a community effort for us to fight COVID-19, and everything that we can do, we should do to help one another in the country. It's a time of need. And it's a time when all South Africans can come together and just show our strength as a country. So please feel free to contact me for any questions you have. I've put up my number at my office. You can also get me at the ICU at Charles Matseke. This is my email, and that's me on Instagram. So please feel free to contact me, and let's see if we have any questions.
Thank you, Dr. Khan, for a really great presentation. So we don't have too much of time, but I will pose one question to you just regarding the prophylaxis in terms of vitamins and zinc. I know many healthcare workers are advocating taking it. What are your thoughts? Is there any merit in taking these vitamins? And if so, what vitamins do you suggest to somebody who's working on the front line and exposed to the coronavirus? So say somebody like me who's vaccinated, but I'm still working with patients. Would you suggest I take any vitamins? Because normally I don't believe in vitamins. I think you should eat well, and that should be fine.
So interestingly enough, we don't have any hard and fast clinical trials to say that this mix or cocktail of vitamins does better than that, or that specific vitamins are going to cause a great benefit. As I said before, it's from the fact that we found a low vitamin D level in a lot of the coronavirus patients that we advocate for vitamin D. Zinc is as a basis of an immune booster, and so is vitamin C. There is a clinical trial ongoing in vitamin C in corona, but it has not been published as yet. Personally, I would take, or I do take vitamin C. I take about 1 gram a day, probably take a little bit more than that. Zinc, I take 100 milligrams twice a day, and vitamin D, I take 50,000 units per week. I also take a vitamin B complex, but that's because vitamin B levels, if they're low, you tend to have a lack of energy, and the way we work, we need all the energy we can get, so that's a booster. But vitamin C, vitamin D, and zinc, I think, would be your best bet if you're going to take something.
Yeah, I think we'll continue this chat a little bit later because there's many things to talk about here. But I think now it's 7:30, and we'll now move on to our next speaker. Thank you, Dr. Khan. Marika, you can now move on, and we can proceed with our agenda.
Thanks, Prof. Maharaj. Thank you, Dr. Khan. That was really great. Before I introduce our next speaker, I just want to make mention the Lancet IT team has posted in the chat box. If you can just have a look there, it is typed out attendance register, and there's a link. So it's very important that you, after completion of this evening, at the end, just click on there. Well, you can click on it now as we speak as well. Click on there just to complete the attendance register, because we need that information, and that will create the link for you to receive your certificate and your points after the event. And also, I just want to make mention that if any of your colleagues missed out and they perhaps ask you, or you want to revisit this whole event afterwards, then you can go onto the Lancet Laboratories website It's www.lancet.co.za, but we will put that in the chat box as well, just for your ease of reference. Then afterwards, in about 3 days after the event, that will be available on the Lancet website. Then there will be a MCQ, multiple choice questionnaire, that will go together with that to also still obtain the points. So anybody that wants to attend afterwards can do that as well and still get your CPD points for that. Okay, so then we'll move on to our third speaker and panelist, neuro-otolaryngologist Dr. Shapar Motakev. Dr. Motakev is the head of the otorhinolaryngology and head of the clinical unit for ENT, head and neck surgery at Charlotte Maxeke Hospital Academic in Joburg since 2016. She's completed her undergrad and postgrad ENT specialist training at the Wits University and obtained her fellowship from the College of Otorhinolaryngology of South Africa. Dr. Motakev has a special interest in neuro-otology, endoscopic ear surgery, rhinology, snoring, and sleep apnea. So thank you, Dr. Motakev. We hand over to you for your presentation. Welcome.
Hello. Hi, can you see me? Good evening, everybody. And thanks very much for invitations. And okay, can you see my slides?
Not as yet, Dr. Motakev. We can see you, or at least we can see.
You can't see my slide.
No, and I think you must put your camera a bit down so we can see you, because right now we're only seeing your glasses and hair.
Oh, sorry. I am sharing my slides. Can you see my slides now?
No, not as yet.
Oh, that's so strange. Because I'm sharing it. Let me see. Do it again. Share again. Close. Include others. Oh no. Hello?
Are we still here? Okay, perfect. We can see your screen now.
Can you see what you see? You see the bits, isn't
Yeah,
it?
we can see. No, we see your emails where it says join live event.
Oh, I don't like that one. Sorry. Do you see Wits University now?
No, not yet. Now we see nothing.
Do you see my slides now? That's so strange. You still don't see my slides?
No, not yet.
I can see my slide. I don't know why. Can we please help Dr. Motakev if somebody says? I don't know why it's not showing. Sorry.
Okay, that's much better. At least you've adjusted the camera quite
so
nicely.
you can see me. I just
see you.
Why we are not seeing the slides. That's strange. As you
Okay, while we're busy sorting Dr. Motakev, I think we can just allow her some time to get her presentation sorted. We can move on to our fourth speaker in the meantime, so we'll just swap them out. Our fourth speaker and expert panelist, clinical hematologist Dr. Lindsay Earlham. Dr. Earlham is the head of the flow cytometry department for Lancet Laboratories and also head of the thrombosis and hematosis unit. She obtained her bachelor's degree in medicine and surgery cum laude from the Wits University. She completed her postgraduate fellowship at the Fellowship College of Pathology and Hematology South Africa, also cum laude, and her postgraduate specialist training from the NHLS South Africa. So we welcome Dr. Earlham. Thank you, Doctor. We hand over to you for your presentation.
Thank you very much. Should I share my screen now? I see Dr. Motakif is also managing to share.
Dr. Motakif, are you sorted, or can we switch over to Dr. Earlham for the moment?
Hello.
Are you up and running on that side, Dr. Motakif? Dr. Motakif, you seem to be muted.
Hello.
Yes, Doctor. Are you able to share your slides? Do you want to present? Are you sorted?
Okay, can you hear me now?
Yes, we can.
Yes.
Okay, can you see my slide?
They were up a few minutes ago, but now they seem to have gone off again.
Oh. So should I just share again?
Yes, please.
I don't know what's going on. Yeah, I don't know. It was doing it just now. No, it's doing it again. I don't know why it's not.
Okay, so I think, Dr. Motakif, while we're sorting you out,
Yeah,
if we
let's
can
go
perhaps
to the
hand
next.
over
Yeah,
to
I
Dr.
don't know.
Earlham, and then we'll get you sorted in the meantime. Sorry about that.
No, no,
Dr.
no.
Earlham, you can present for us.
Thank you. I'll go ahead. Can everybody see this?
No, we're not seeing anything else yet, Dr. Earlham.
Still not. I think I might be having the same problem.
Marika, do you want me to try and see if I can share my presentation?
Yes, please, Prof, if you don't mind. I haven't formally introduced you yet, but if you just want to test and see.
Can you see mine?
Yes, I can see yours, Prof.
Well, then I think I should go ahead and present then, if you can't see mine.
Yes, you're welcome to.
Okay, will you just do the introduction?
I can introduce you quickly. So Prof. Maharaj, aside from being our chair for the evening, and thank you for chairing, Prof, much appreciated. Prof. Maharaj is currently the academic head of Department Otorhinolaryngology, Head and Neck Surgery at the Wits University, with over 10 years of clinical experience as an ENT specialist surgeon. Prof. Maharaj has a special interest in endoscopic ear surgery, skull base surgery, salivary gland disease, and head and neck infections. He is a firm believer that clinical skill is the foundation for service delivery and has successfully performed well over 100 endoscopic ear surgeries, which includes repair of subtotal or total perforations, cholecystoma surgery, ossicular reconstruction, stape surgery, eustachian tube, and lateral base skull surgery. So Prof. Maharaj, without further ado, thanks. I'm going to hand over to you.
Thank you, Marika. So the first thing I'd like to do is I'd like to thank Reza for arranging this webinar. I think in this period where we're about to enter the third wave, the information that we can get out to our physicians and to our colleagues is very important in us overcoming the pandemic. And when we focus on specific areas, I think we just build on the knowledge base. they've managed to put together an excellent panel. There's a good array of speakers, and barring the few technical issues that we are facing right now, I think everyone that attends this, whether they attend it now or revisit it at a later stage, will certainly benefit. The two speakers thus far have been of an excellent quality. To start off with, I'd like to say that I don't have any conflict of interest and nothing to disclose. I'm going to speak a little bit about ENT dysfunction as a general topic, and Dr. Motekev will talk more in depth in terms of the neurootology. So I'd like to mention a few things about the neurologic and otologic dysfunctions, and in particular focus on their role in early diagnosis of the disease, because we all know as the disease progresses, it may become more difficult to manage, and as the virus starts affecting the lower respiratory tract and the damage caused there, the patient would need to be admitted to hospital and may actually progress to an ICU and ventilation. And currently, as we know, these beds are a short supply. So if we can pick up these patients at an earlier stage and perhaps institute some kind of treatment or some kind of protocol to make sure that they do not progress, or identify those that are going to progress, I think there's definitely a role to be played by the early manifestations of the disease. The second thing I'm going to talk about is the pathophysiology and the pathogenesis, which is obviously evolving every day as more and more studies are being done throughout the world. Then we'll talk a little bit about the recovery rate and a quick review on the prevention strategies and appropriate treatment modalities. So, as the other speakers have mentioned, the clinical manifestations were first documented as fever, fatigue, and dry cough, which were the first and the most common presentations. Thereafter, in China, they noticed that there was other manifestations such as dyspnea, anorexia, and sputum, which were reported in 25% of cases. And at a later stage, we then found the sore throat, rhinorrhea, headaches, and the areas that the ENTs deal with. So, as we know, coronaviruses are large enveloped RNA viruses that usually cause mild respiratory illness in animals and humans. And to date, there have been 2 outbreaks. The first one being the SARS, the severe acute respiratory syndrome, and the Middle Eastern respiratory syndrome, or the MERS. And despite the neuroinvasive properties of the coronaviruses, there have been no reports of inner ear or vestibular cochlear nerve disorders, or for that matter, olfactory specific disorders in the other pandemics. We all know that viral upper respiratory tract infections have been casually linked to new cases of ear infections as well as sinonasal infections. As the pandemic progressed, there were many reports and case series talking about chemosensitive disorders. And the first European cases of chemosensitive disorders found in COVID-19 patients ranged from 19 to 88%. So that's a very high range. And I think as more studies are being done, we will be able to quantify what do we mean by chemosensitive disorders. In South Korea, China, and Italy, a significant amount of people were presenting with anosmia and taste disturbance. So why is it important? So as we mentioned initially, the magnitude of the pandemic and its indeterminate pathogenesis, as well as a wide variation in the clinical manifestation, by increasing our awareness and early identification of these symptoms, they may be able to enable us to diagnose and isolate these patients and perhaps even offer them some kind of treatment. Viera noted that asymptomatic patients, which represent still about 4 to 5% of cases, may actually facilitate silent transmission. So perhaps these so-called asymptomatic patients may not be as asymptomatic as we think they are, and they may be presenting with neurologic and otologic dysfunction, which we've not been identified as yet. So how does this happen? So in terms of the nose, it may be due to direct invasion through the olfactory bulb, and this is due to the intranasal infection. What we have noticed is that the nasal mucosa has got one of the highest concentrations of the virus in any other area. And in animal studies that have been reported, that there may be introduction of the virus via the olfactory bulb, and this can be causing the neurological and chemosensory dysfunction. Lotore did a very good study and reported that there were many uncertainties regarding the pathophysiology of smell and taste, and this may only be clarified when we have enough histopathological samples that may be analyzed. However, in order to get this, we need to obtain these from patients, and the whole aim of this is to actually prevent patients from passing on. So this is almost a catch-22 type of situation. So just a quick mention about prevention. So if we can screen for early symptoms such as the loss of smell and taste, we may be able to come up with an effective strategy to prevent the spread of infection amongst patients that have the infection, and also perhaps institute some kind of therapy to prevent the virus from progressing, as well as treating the smell and taste. One of the things that we should note is that the sudden onset of anosmia and ageusia, which is taste disturbance, is considered an important symptom, and we may try and find some biomarkers for early diagnosis and isolation of these patients. Now, up till now, most of our screening has been on temperatures, and I think most of us have now got temperature fatigue. Everywhere you go, they take surface temperature, which, as we as physicians know, is of no use to anyone. But because we want to follow the protocol and fill in all those pages, we continue doing that. And the only reason why we continue doing that is that we don't have better questions. I mean, at some hospitals or some areas that you enter, they're still asking, have you traveled? And I think we're very far from that. I think we need to devise some better questions, and perhaps focusing on smell and taste may be a way of diagnosing these viruses at an earlier stage, especially in medical institutions such as hospitals and doctors' rooms. So I'll come back to the treatment modalities. I've just put this in here regarding olfactory training. This is something that I thought I'd share with you in terms of essential oils and trying and recuperate. So I have tried this myself and it does work, but this is something we'll review at the end of this. So chemosensitive dysfunction, what does it mean? Basically, it means loss of taste and smell, and we've divided these into 4 types. In terms of taste, we start at a complete loss of taste, and then a distorted taste perception, and then a reduced ability to taste. Now, these may be very difficult to differentiate on a clinical basis. And the last one, which is gustatory hallucination, or gustatory hallucinations, where one can taste without an actual stimulus. I think these things are very difficult to quantify, and most of us in clinical practice would correctly identify with a complete loss of taste. So either a patient can taste or not. When it comes to smell, I think this is a little bit easier because, as we all know, the anosmia has been explored en length, and this complete loss of smell has been reported in patients, and many articles have been written up. In fact, there's a lot of research happening at our institution as well. We have data regarding anosmia and the recovery, and this is something that we intend to publish. At this point in time, it's still unpublished data. We hope to publish it and have some peer review, and we can give you some feedback perhaps in later webinars. That's followed by hyposmia, which is a reduced ability to smell, and then the other 2. What we noticed with the coronavirus pandemic is that the smell and taste disturbance occur without any rhinorrhea or nasal obstruction. So you can just get a loss of taste or loss of smell, and sometimes both of them. And this is often seen in the early stages of the disease. Most of the tests, however, are unreliable. And Vieira et al. Stated that we need an objective evaluation that can be validated, repeatable, and we need to standardize these tests so that we can measure the frequency, extent, as well as the clinical characteristics of these dysfunctions. So the pathophysiology at this point in time, the exact pathophysiology is not well understood. However, we believe that it may be a viral invasion of the olfactory epithelial cell types especially those that have a high expression of the ACE2 and the TMPRSS2 cell types. There may be also an inflammatory response, which can lead to further damage of the neuronal pathway, the mucosa, or damage to the supporting structures and the supporting cells. In terms of otologic dysfunction, the otologic disorder may also herald the onset of COVID-19. Hearing loss has been documented as a late complication of the disease. So what is it that causes this? Here it's a little bit different because it may not be the same mechanism that is causing the olfactory and taste disturbances. Here we believe it may be a cross-reaction between the viral particles and antigens that are present within the inner ear. The virus may also be transmitted via CSF, and when this does occur, there may be features of brainstem involvement. And we believe once again that the coronavirus has got a predilection to the ACE2 surface receptors, and these are found abundantly on both neurons and glial cells. One of the proposed mechanisms for the hearing loss may be due to ischemia, and this may be at the hearing center, which may be due to the coagulation disorder or the thrombogenic phenomena, which I'm sure our other speakers will expand upon as related to the SARS-CoV-2 virus. So what we did is we specifically looked at alterations in taste, smell, and hearing and balance under the broad umbrella term chemosensitive dysfunction. And what we noticed was that the trends seen in our patients was that the loss of smell and taste was more common in the early stages of the disease. The hearing loss and the otologic symptoms may be found at any point of the disease process. However, there were unusual presentations of the disease, and this included tinnitus and sensorineural hearing loss. Viral infections have been implicated in both congenital and acquired cases of hearing loss, and these may both be unilateral and bilateral. As suggested, it is typically sensorineural, which is damage to the sensory pathway and not so much the conductive pathway. A quick recap for those of you that are not familiar with the terms conductive and sensorineural. Conductive hearing loss is from the outer ear right up till the tympanic membrane, including the ossicles, and then sensorineural hearing loss is from the cochlea and including the 8th cranial nerve and the higher centers. So when we have a combination of this, we describe it as a mixed hearing loss, which has both conductive and sensorineural components. And these have been found in these patients as well. So one of the things that we did last year when the virus was still rampant during the second wave throughout the world is we did a systematic review where we looked at the otologic manifestations of the SARS-CoV-2 virus. And this was done in accordance with the PRISMA guidelines. Otologic dysfunction was defined as any subjective or objective impairment to the normal otologic, vestibular, and audiologic function of the ear. In our search, we found 62 articles, and these articles were then screened by the investigators and the authors so that we reviewed the abstracts, and 7 articles finally met the criteria that were then analyzed to come up with a discussion. This article has been published in the Laryngoscope, and if anybody would like to review this article, it's available on PubMed as well as Google Scholar, but you're welcome to email me and I can send it through to you. And what we found was that from the studies done, the age varied from 20 years to 60 years. And overall, the number of participants or the number of subjects in all the case reports and case series totaled to 28 patients. These patients ranged from throughout the geographical regions, ranging from China, Egypt, Iran, and 2 were from Turkey and Germany. 1 was from Thailand. All patients presented with hearing loss, and 3 of these patients had otalgia, vertigo, and tinnitus. It's also important to note that these patients tested positive for the coronavirus using RT-PCR. 8 of these patients had MRI scans, as part of their investigation, and 5 of these patients had CT scans as workup for the sensorineural or the hearing loss that was present. So moving on to treatment modalities, there are many agents that are being tried at this point in time, and no specific therapy has been formalized at this point in time. There's a high probability of spontaneous recovery. So when we're looking at the treatment modalities, we need to weigh out spontaneous recovery versus potential risks. So to quickly go through this, I've grouped them together, and as you can see, specifically with the anosmia, normal saline has been the most commonly prescribed medication, and that is usually in the form of a nasal spray, intranasal spray. After that, paracetamol and mucolytics. Corticosteroids, we believe, may play a role, whether it's both topical or oral, and there are studies underway, large studies in different ENT centers looking at the role of corticosteroids. And I thought I'd just mention vitamins, which we will talk a little bit about in the discussion. However, the natural history is that most of these patients will regress within 30 days. And various articles have highlighted that these symptoms usually occur 4 to 5 days after the onset of other COVID-19 symptoms, and the duration usually ranges between 21 to 28 days thereafter. There's a higher rate of recovery within the first 1 or 2 weeks. However, there are patients who are still presenting with these symptoms who have not recovered as yet. Long-term follow-up and long-term studies are required to see what are the factors that would predispose a patient towards making a poorer recovery or not recovering at all. As mentioned, residual mild or moderate hyposmia and hypergeusia is seen in anything from 60 to 30% of cases that have been documented in the literature thus far. So if one looks at that graph, you can see the recovery, and as time passes, the patients seem to be recovering. Within 28 days, most of them have recovered. So I think I'm going to conclude now, and hopefully our other speakers will now be ready. What we're now seeing is an increased frequency of chemosensitive dysfunction, and the possible pathogenesis of smell and taste disorders is still not yet resolved, and lots of work needs to be done in this area. However, most patients are going to recover spontaneously within a short period of time, and at this point in time, corticosteroids and gustatory training, olfactory training, may be the treatment modalities that we can offer our patients. So I thank you for listening, and I'm going to now see if there are any questions which we can attend to. Okay, so we have some questions, but I think we will discuss this during the discussion. Marika, I think we can now introduce the next speaker.
Yes, thank you, Prof. Maharaj. That was very insightful. Thank you very much. We thoroughly enjoyed that. We're going to move back to Dr. Olam. Doc, if your presentation is sorted, we can just try put yours on and just see if that works. Then we can move back to you, please.
Are you able to see the presentation?
Yes, we are.
Excellent. That's great news. Thank you. Thank you very much for this opportunity. Just to mention, in terms of the introduction, I am a laboratory hematologist, not a clinical hematologist, so my talk will be orientated from the laboratory perspective. So I was asked to prepare something brief from a COVID hematology sort of point of view. And I thought, just given the enormous press coverage that clots in relation to the vaccines has generated in both the national and the international press, that this was a topic worth just looking at. So I will briefly discuss the basics of vaccine-induced immune thrombotic thrombocytopenia, which we'll now call VITT for simplicity's sake. It does also go by other similar names, TTS and VIPIT, but we'll stick with VITT. And just to mention, the date there is indicated as May 2021, and as with everything related to COVID, we find ourselves in a continuously evolving situation where we might find in a couple of months' time, things that are spoken about now are actually later proved with more evidence to not be the case. So it's very important to consider at a specific time point what one is reading about in this respect. So it is a very new syndrome. It's only been described since late February 2021, really, that it came into the literature as a prothrombotic syndrome, which was being observed in a small number of individuals following the receipt of AstraZeneca vaccine. But then, as we are all aware, in April, the FDA paused the use of the J&J vaccine, and that was then followed in South Africa by our pause to the vaccination program as well. What's important is that it's these two specific adenoviral vector-based vaccines which have been implicated in VITT. It hasn't been associated with the other mRNA vaccines as yet. And very importantly, although it's got this huge press and everyone you speak to when you mention a vaccine seems to ask you about clots, it is rare. The exact incidence is unknown, and I think as more quality data becomes available, that might become clearer. It was postulated maybe 1 in 500,000, then maybe 7 million in women under 50 who seem to be what appears to be the highest risk. But one should also just bear in mind that in many cases in the countries where this has been examined, this was the group of people who were actually receiving the vaccine at a higher rate than the rest of the population. But just to mention, as we go into the pathophysiology, that may be a factor though, because autoimmune diseases are more common in women of this age group. What was observed with this new syndrome was a high mortality, with an in-hospital mortality of about 40% being described. Again, late recognition may have played a role, and certainly part of this pausing of the vaccine program was to investigate and then to educate healthcare professionals in terms of recognition of this syndrome. The pathophysiology is not fully understood, but what it has resembled is heparin-induced thrombocytopenia but very importantly is there's no exposure to heparin with these vaccines. It's not a component of the vaccine, but it's caused by autoantibodies that recognize the platelet factor 4 bound to platelets. This results in platelet activation and stimulation of the coagulation system, and then clinically significant thromboembolic events. The mechanism by which this is occurring with these adenoviral vector-based vaccines is uncertain. Is a neoantigen binding to platelet factor 4, is an antigen from the virus, from the vaccine binding to platelet factor 4, and we're getting the generation of a neoantigen? I think that still needs to be elucidated. So what is really the presentation? So thrombosis and thrombosis at unusual sites has been a feature of this condition, and there may be multiple sites. So for instance, the cerebral, splanchnic, ophthalmic veins have been presentations with ischemic strokes and acute limb ischemia. The thrombosis has been both venous and arterial. It's been associated, which is very atypical for your typical venothromboembolism that one observes in clinical practice, is the thrombocytopenia, which is typically moderate to severe. There's been a very typical interval, as one knows with the vaccines. Symptoms often occur thanks, just to the side effects of the vaccine within the first 1 or 2 days. But this is really a disease of the second week, or certainly from 4 days. So in the South African guidelines saying 4 to 16 days, but 4 days to 4 weeks post-vaccination being a described interval. Some of the individuals who've presented have described a flu-like illness with this condition, which is probably related to the inflammation. What's very important is that these patients are COVID negative. Of course, as has been mentioned during this talk, COVID is a very prothrombotic condition, and exclusion of COVID itself is very important. At this time frame of just 4 days or a week after the vaccination, one wouldn't expect sufficient immunity yet from the vaccine. So the possibility of COVID with atypical thrombosis has to be considered. So in terms of just where these atypical thrombotic events are occurring, symptoms like severe headaches in the 2nd week, visual disturbances, seizures, severe abdominal pain, those are all symptoms that should raise some concern of this rare condition. So the differential diagnosis needs to be considered. Obviously, one has to think of it just your typical venothromboembolism sort of picture that needs to be considered. If there is thrombocytopenia, one needs to consider what could the other causes of thrombocytopenia be, because this is not the most common cause of thrombocytopenia in a patient who's just been vaccinated. So first of all, from a laboratory point of view, you always want to consider, is this a true thrombocytopenia? So things like platelet clumping have to be excluded. ITP would be a more common cause of a thrombocytopenia after a vaccination, but typically these patients have bleeding symptoms, and one would not typically expect thrombotic symptoms here. An important condition to differentiate it from is TTP, or thrombotic thrombocytopenic purpura, which is a condition which might have, which has both thrombocytopenia and thrombosis, as the name suggests. But what's very important here is it's associated with fragments on the peripheral smear, significant fragments, and microangiopathic hemolysis. So things like a high LDH and a low haptoglobin, and your altered unconjugated bilirubins. Also important in the South African setting is to consider infections like malaria and HIV. And then just more widely, other autoimmune conditions, something like an antiphospholipid syndrome, hematological diseases such as myeloproliferative disorders or paroxysmal nocturnal hemoglobinuria are conditions which might present with thrombosis in atypical sites like this. And then, of course, the medications. And if the patient had been exposed to heparin, of course, HITs would have to be considered. So what sort of investigation should be done? One would start with a basic full blood count with platelets, and of course a review of the smear, as I've mentioned, just to check that it's a true thrombocytopenia and to check for fragments. As part of any thrombotic or hemostatic workup, you would do an INR and a PTT. Very important then is the D-dimer, which is typically markedly raised in the setting. Often they say 4 times greater than the threshold. Your fibrinogen would often be low or low normal. Then what's been reported as positive and what gave the clue to how some of the pathophysiology is the commercial ELISAs for the platelet factor 4 heparin antibodies. But just to note that these results are not going to be available very quickly. So unfortunately, one has to make a clinical decision typically without the availability of these commercial ELISA tests. The South African Medical Journal, I just want to draw everyone's attention to, has recently published an online article under Professor Barry Jacobson on the recommendations for the diagnosis and management of vaccine-induced thrombotic thrombocytopenia. And they've come up with a 4T score, which is based on the original assay for original score for heparin-induced thrombocytopenia, looking at the causes of the thrombocytopenia, the degree of the fall, the timing, and the other cause, and the thrombosis, which is very, very helpful. So just in terms of the name, it just is nice and simple to give a clue to the condition. So V for vaccine, and it's these 2 specific adenoviral vector vaccines at the moment, the AstraZeneca and the J&J. The interval is basically 4 days to 4 weeks. Thrombosis, often at atypical sites, and a thrombocytopenia, which is typically moderate to severe. The importance of recognizing this condition is because the management is different. So where possible, and because the numbers of patients who present with this should be few, it is a rare condition, this should be done by a specialist team who could manage such a patient. The patient would need to be anticoagulated, but the consensus, very importantly, currently is that it's not heparin. Platelet transfusion should be avoided, and warfarin should not be used in the acute event. The options that are appearing the most popular are your direct oral anticoagulants, so rivaroxaban being the most commonly used, but also your fondaparinux should be considered as well. In terms of intravenous immunoglobulins, certainly in some of the international guidelines, this is advocated. There is some concern locally in terms of this, just in terms of cost and availability, but certainly this has an immune modulating effect. Because of the severity of the condition, the monitoring is advised, certainly in the South African guidelines, and this would be on the relevant specific anti-factor 10A assay. So just to mention a few points with this, it's completely different from measuring a factor 10. It's a different test. And also one has to specify which anti-factor 10A assay one is requiring. So for instance, the rivaroxaban assay is completely different from the fondaparinux assay. So it's very important that the laboratory knows exactly which agent one is assessing. And this is typically performed as a peak level 3 hours post the dose. So the sample needs to be tested and referred to the laboratory as soon as possible. And especially if there's renal dysfunction or extremes of weight, this would need to be very carefully monitored. The duration currently advised in guidelines of anticoagulation is about 3 months. So just some special notes is this, as I've mentioned already, is an evolving situation. This is the current understanding, and things could change as more is understood. Currently, there are no preventative strategies, so there's no role in taking aspirin before vaccination or after vaccination to prevent it. Unfortunately, aspirin doesn't seem to block this platelet activation in this situation. There's also no role for screening for the presence of these antibodies prior or after the vaccination. Unfortunately, a few percentage of the population has these antibodies as sort of an incidental, poorly understood finding. So there's no role for the screening, and there's no role for aspirin to prevent this condition in terms of current understandings. And also just to stress, a previous history of venous thromboembolism is not a contraindication for vaccination with these current vaccines. So COVID itself is associated with a severely increased risk of venous thromboembolism as the disease is a prothrombotic condition. So these patients are far more at risk of developing a thrombosis due to COVID-19 than they are to developing this very rare situation of VITT. And there's no indication that any of the traditional risk factors currently are associated with VITT. So as in the next point, there's no information on increased risk with hematological disorders, pre-existing risk factors for thrombosis or autoimmunity. Currently, plasma exchange is not advised in consensus recommendations, and the use of corticosteroids has also been a bit controversial. Some advocate possibly for its use at lower platelet counts, but it's currently not included in general in consensus recommendations. So just to stress, the mortality of COVID-19 and the risk of life-threatening thrombosis due to COVID-19 is far in excess of the very rare risk of VITT. Even just something like a cerebral vein thrombosis due to COVID-19 occurs at a far higher order of magnitude than the rare risk of VITT. And these are just some references, as I mentioned, that Professor Jacobson and his team have recently published some guidelines in the South African Medical Journal, and then the American Society of Hematology and ISTH, which are some of the main thrombotic thrombohemostasis sites, also have published guidelines on the topic. Thank you.
Thank you very much, Dr. Elam. That was a very concise and in-depth talk. I think you've addressed all the issues rather adequately, and this was something that I wanted to be brought to the fore, considering the whole vaccination and the contraindications and all these naysayers to the vaccine. So I think you've managed to give us some feedback regarding that. I don't see any pressing questions at this point in time, so what I'm going to try and do is perhaps save the questions for the discussion which we're going to have at the end. and let Dr. Motikev present if she's ready. Dr. Motikev?
Yeah, I'm sharing the screen. Still is not coming, so very strange, huh? It doesn't come. Yeah, that Windows is not coming.
Yeah, we can see your screen now. It says Wits University. I think you should just click on the PowerPoint. There we go. Okay, excellent. I think you're good to go. You just have to unmute yourself, Dr. Motikev.
No, but I'm mute. I can't unmute.
No, you're unmuted now. Just share your screen. Everything is perfect. If you just go to the
Can you hear me?
Yeah, we can hear you. Yeah.
Oh, okay. Can you see my screen?
Not yet. Now click on that. Yeah. Okay. There we go. We can see your screen.
Okay.
You can start your slideshow. Perfect.
Yeah. Sorry. Yeah. Can you see? Can you hear me as well, Prof?
Yeah. No, it's perfect. Brilliant.
Okay.
Let's go for it.
Yeah. Thanks very much, everybody. I don't know what this has happened. Never happened to me that that couldn't share. And anyway, thank you very much, everybody, and thanks for staying this far. And I'm just going to discuss neurotology and COVID-19 and what do we know so far. Just to that we have discussed that, of course, by the other speakers, that by the end of 2019, SARS-CoV-2 was identified as the cause of a novel lower respiratory tract infection in China. As on the 11th of May, there has been more than 150 million cases and more than 3.3 million of death. It is known to cause primarily a pulmonary disease, that's pneumonia and ARDS. However, there are many extrapulmonary disease that has been emerged. Now, if you look at this picture, we are quite aware of this one by now. We know that how it has been caused a disease in multiple organs. Now, as far as the ENT is concerned, we have seen that from the beginning that a lot of ENT symptoms are presented in patients with COVID-19. Some of them by now we are quite aware of them, that is anosmia and ageusia. That has been well documented. However, as Prof. Maharaj also mentioned, the exact pathogenesis is not fully understood yet. The others like sore throat, cough and rhinorrhea and nasal congestion, they've got common symptoms that are shared by many other upper respiratory tract infections. As far as the audiovestibular symptoms is concerned, that will be the hearing loss, tinnitus and vertigo in COVID-19. Still, the association is not fully understood. Hearing loss, as Prof mentioned as well in his talk, is that divided into conductive and sensorineural hearing loss. As far as the conductive hearing loss is concerned, we have definitely been cases being reported, and in this particular scenario, it is due to the middle ear effusion. Just to the background of that, there have been SARS-CoV-2 that have been isolated in the middle ear as well as in the mastoid cavity. The other area that plays a role in middle ear effusion is the eustachian tube. Eustachian tube mucosa is part of respiratory mucosal inflammation, so that can result in middle ear effusion and conductive hearing loss. The more area that we're still not very sure how much plays a role in COVID-19 is the sensorineural hearing loss. We know that sensorineural hearing loss is common in many viral infections, in cytomegalovirus and herpes, measles, just a few, mentioned a few. So it makes sense that maybe the SARS-CoV-2 also potentially causes sensorineural hearing loss in COVID-19. Although the two previous coronavirus, which was SARS and MERS, they did not have sensorineural hearing loss at all. So I'm just going to go through a little bit of a development from the beginning of this of COVID and the cases that has been reported. So when the study was done by Salepsi in 2021, he published it. He had 223 COVID positive patients. Out of the total patient, only 2 had hearing loss, which makes it 0.9%, and 5 had dizziness or vertigo. They did not mention tinnitus at all. In contrast, when we compare with loss of smell, was 71 cases, which was 31.8%, and loss of taste was 34.8%. Another study was done by Elibol, again out of 155 patients. They found that only 1 patient had hearing loss and 2 patients had tinnitus, and there was not mention about dizziness at all. Again, just a comparison, the 55 patient had anosmia and 25 patient had ageusia. So if we go by these ones, we see that no, the hearing loss and also tinnitus and vertigo must be quite insignificant in this disease. However, in 2021, the article published by Pheidon, what they did is that to compare the number of patients that are presented to their departments with a sudden sensorineural hearing loss from 1st of April to 30th of December in 2019 and 2020. The 2019 would have been the pre-COVID and 2020 during the COVID. What they found was that there was in fact, a rise in the sudden sensorineural hearing loss in the department. In 2020, they had 68 cases, meanwhile in 2019, 41. And the subjects also were but they were younger. The 2019 was 67, meanwhile 2020, the mean was 51.7. So that is start, showing that yes, maybe there is some associations. Mustafa, in 2020, he looked at 12 asymptomatic patients and he did a full hearing test. He did a Puton hearing test and a transient evoked otoacoustic emissions. What he found that this patient in fact had a mild hearing loss in the high frequency, and none of them actually complain about hearing loss at all. And their hearing loss was quite mild in high frequency. He also looked, as we said, on the transient evoked otoacoustic emission, which showed the reduced amplitude. Now that is an indication of an outer hair cell damage. So here we start thinking, yes, that possibility again, that there are some hearing loss in this patient. There was there was a systematic review that was done by Al-Mufarraj and Monroe in 2021. The reason I put that here was also very clearly shows that you can see they looked at the 28 of the publication. Out of all of the 22, there were only a few that they were really good. You can see that I've actually put them to green. And one of the good ones is actually from Prof. Maharaj and Hari. So it was from our department. So just to show that there is a lot of study, a lot of publications is out there related to this hearing loss and vertigo and tinnitus, but there are very sort of case reports, and they are not very high value in terms of that they couldn't have published to say how much their hearing test, whether they've done a proper hearing test on them. So it makes it a bit difficult to assess the final, that whether there is an association. This one is just the pilots in that, which I'll go into it. So what they've done is that they Al-Mufarraj and Monroe in 2020, when they looked at the systematic review, what they did this kind of pool prevalence among all of the articles. So then they come up with a hearing loss of 7.6%, vertigo of 7.2%, and tinnitus of 14.8%. So again, it's also not very high, and considering that many of these articles in fact considers that they were not very at high quality, it makes it difficult to come to any conclusion. So again, in hearing loss, we're just finding a few publications on that. So up to February, there have been 9 reports of a sudden sensorineural hearing loss, which seem to be in associations with COVID-19. And then what the Becker in their article actually recommend is that when we are looking at the patient with sudden sensorineural hearing loss, we should look at the possibility test them for COVID, or see if they had COVID in the past by means of doing antibodies. So, and then when we go to vertigo, vertigo has been also in some of the articles have been talking about that there's a possibility. The articles that have been reported, they have been either presented as a single only presentation or in associations with other otological symptoms. So Malayal and Mohan, they reported a series of 6 patients that present with a persistent rotatory vertigo as initial symptoms or as late of 13 days after being COVID. Then there is a few of these case reports at 87, 84 years old presented with an acute labyrinthitis as the only presentation. And then this more dramatic one is an 18 years old girl that presented with vertigo and bilateral sensorineural hearing loss. And the final diagnosis was actually intralabyrinth hemorrhage, which was diagnosed on MRI. And as far as the tinnitus is concerned, there is still very few publications, and many of the reports that they talk about tinnitus, they were in associations with hearing loss. American Tinnitus Association have announced an increase in tinnitus severity in pre-existing patients. But of course, this can be explained by psychological connection between tinnitus and stress. So now when we want to look to say, okay, how this COVID-19 can actually cause the hearing loss or tinnitus or vestibular or vertigo. So it actually, if we looked at this one has been explained just now earlier on, but if we're just looking at the virus, we can see the virus has got the spike, and the spike has to binds with the ACE2, and then of course TMN PRSS2 as the primer. The way that it does that is by 4 different ways that it causes damage. One is the direct cytotoxic effects. The other one is dysregulations of the renin-angiotensin-aldosterone system, which is going to result in inflammation, tissue injury, vasoconstriction, vascular permeability, endothelial cell damage, and thromboinflammation. So then here, endothelial cell damage, and of course that causes inflammation and thrombosis, and then the immune response that causes the cytokine release syndrome. Now going back again to our cochlea and vestibular system, we can see that any of these can actually result in damage to cochlea and to vestibular system. So how does the COVID-19 can cause that? We know that the ACE2 and TMN PRSS2, of course, we know there's a lot in many of the extrapulmonary organs, and the SARS-2 is transmitted mainly through the respiratory tract. So the question is that how does all of these viruses actually reaching to extrapulmonary? And so there have been identified some virus in blood, urine, and feces. So if we go back again to see what happens in audiovestibular dysfunction, there was a couple of mechanisms that has been basically more postulated that could be the cause. Virus have been found in the middle ear and mastoid, so it's possible that it diffuses into the inner ear through the oval and the round window. There also have been in mice reported that the SARS-2 binds with the ACE2 receptors, which have been found in epithelial cells of the middle ear, stria vascularis, and spiral ganglion of cochlea. So that will be a direct cellular injury. Other one is that the COVID-19 is a neurotropic, which we've seen that it causes both mono and multiple cranial nerves neuropathy. Anosmia and ophthalmoparesis has been postulated can be mononeuropathy. Of course, anosmia, they've got many other possible causes. That's a different talk, and Prof deals with that about this. And then we look at the Guillain-Barré syndrome has been reported in COVID-19 in multiple neuropathies. So what the final is that, so the SUSA have to say that it's possible that the vestibular cochlear nerve also maybe is involved, and the patient can present with vestibular neuritis and sudden hearing loss. The other postulated is that the midpoint of the hearing is in the temporal lobe, and there is AC receptors in temporal lobe. So they thought maybe that SARS binds with the ACE2 in the temporal lobe. Another thing, of course, is that the SARS elicits cytokine and other inflammatory reaction in temporal lobe, or maybe the surrounding causing the sudden sensorineural hearing loss. And of course, the SARS-CoV-2 also can result in increased cytokines and inflammatory response, which can cause damage to the cochlea. Eventually, the important one is this microangiopathy. So we have seen that the both can result in labyrinth and cochlear damage. The SAW actually found the relationship between the D-dimer and fibrinogen values and Peotone thresholds at about 4,000. At conclusion, I would say there is a lot is still to do in hearing loss and vertigo and tinnitus and its relations to the COVID-19. We can't come to any conclusion as yet. We have got a highly suggestion that it's possible that there is an association, in particular in sudden sensorineural hearing loss and picture of a vestibular neuritis. That is a good possibility. and we just need to wait for more articles to come up to see if there is indeed association which are of the higher value in terms of the standard of the studies. Thank you very much.
Yes, thank you to Dr. Motekev. That was indeed a very good and amazing presentation. I think that you've done an incredible job in analyzing the data and presenting it. So without much further ado, I think we're going to now move on to the panel discussion. So if all panelists are on board, what I'm going to do is I'm going to spread the questions out so that I think every one of us can address one of these questions. So the first thing that we want to start off with is a vaccine question regarding patients on steroids getting the vaccine. Are there any contraindications, or are there any things that we should take into consideration? Professor Vardas?
There's no published contraindication because of steroid use. Steroid use can cause immune suppression, and we all know that, but there is no contraindication to the use of to taking a COVID vaccine. We don't have any live attenuated COVID vaccines, which I think is a good thing. We've got mainly mRNA recombinant, and the Sinovac is the inactivated vaccine, so there is no contraindication.
And then Professor Vardas, whilst you're still there, what about the flu vaccine and the COVID-19 vaccine? How soon can you take the flu vaccine after getting the COVID-19? Well, the current vaccines that we have, which is the AstraZeneca and the J&J vaccine.
Yeah, J&J and Pfizer. So basically, the recommendation is 14 days. And the reason for that is not because of any interaction between the vaccines, but rather they're trying to, if you're going to have a side effect, trying to attribute the side effect to the correct vaccine. So a lot of people have received a voucher and have had a flu vaccine, and they go for their vaccine. That's entirely what I would recommend as a specialist virologist, and I don't think that there's too much problem with that. So it's really just to keep the side effects, you know, if you do develop a side effect to COVID vaccine, they need to be able to work that out. But it really, there's no physiological reason why you can't have your vaccines close together.
Okay, and then one more question, which is the burning question. I thought
you were spreading them out.
Yeah, what I thought I'd do is I'd give you all the questions, so we don't have to go through. I'm spreading them out.
Yeah.
The new variants and the vaccine. So if you're given a choice, I mean, I'm putting you on the spot here, but which one of the vaccines is more likely to cover, based on your reading, the new variants that we are finding now, in particular the ones isolated in the UK and in India?
Yeah, we don't have much data, so that's the cop-out response for COVID, but we don't have much data for them. Statements have been made by Fauci and others about the mRNA vaccines covering the new variants. We really don't have actual real-life data. So, I think we need to wait and see. Most of the vaccine manufacturers are modifying these vaccines as we speak, and I think they will release vaccines that will cover all variants. So there'll be pan-variant vaccines, but at this point in time, we just don't have the data.
Okay, thank you for that. I think we'll give you a bit of a break now, and then we'll move on to Dr. Elam. Dr. Elam, I hope you can answer these questions because, as you mentioned, you're a lab hematologist. So the question is, are there any hematological contraindications for the AD26 vaccine, oral contraceptives? One of it's asked by Amendri.
I mean, this, I guess, Prof. Vardas could also partly answer, but I mean, certainly in terms of the current understanding is that in terms of this complication of VITT, there's no known contraindications in terms of myeloproliferative disorders, prothrombotic. I mean, we're getting asked a lot, people who've previously had a thrombosis, can they receive the vaccine? And it's actually important that they receive the vaccine to prevent the thrombotic risk of COVID infection, which is far greater than the risk of this rare, unusual form of thrombosis that's being seen with the vaccine. But I think almost every day or every second day, there's someone asking the question, we've had a thrombosis, or someone in our family's had a thrombosis, should we not get the vaccine? And that's all the more reason, if there's thrombophilia, to be getting the vaccine, because COVID is such a prothrombotic illness.
Mm-hmm. Well, thank you for that. And then Dr. Nati wants to find out about what's our opinion regarding prophylactic Ecotrin post-vaccination in an otherwise healthy individual,
Yes,
otherwise healthy patient.
In terms of preventing VITT, there's no role, and the consensus guidelines, all that there's no role for aspirin. There's no evidence currently that it can prevent these autoantibodies from activating platelets. So aspirin isn't advised as some sort of preventative measure in this setting.
Okay, thank you for that. And then Dr. Khan, I think this question would be applicable to you. How long after can one still give or try steroids?
So actually at any point, if you can give it, you're going to dampen the inflammation. Basically, you want to give it before day 7. What we've seen is that a few patients who have been given ivermectin, they postpone their inflammatory storm slightly. So about day 9, they are at maximum in the inflammatory storm. So the sooner the better is the answer. So if the patient comes into you and there is inflammation on the CRP and ESR, then you do need the steroid. If the patient comes into you and obviously it's they're already having now post-COVID complications, for example, they have had the COVID, they over it, and they have a pulmonary embolism, for example, we're discussing clotting. At that point, there isn't a role.
Oh, thank you for that. And then the next thing is also a question from Dr. Nati, and he wants to know, do we hypothesize that HIV, non-AIDS defining patients, are part protected from the severe disease due to their adherence to the antiretroviral therapy regimen, the HAART?
Okay. So there's no evidence that HAART or the antiretrovirals that are used in the HAART combinations that we have shown any efficacy in improving protection of the patients. However, what is possible is that these patients still have a little bit of immune paresis, and they're not giving the full immune storm that they would have given, and that might be a reason for why they're doing a little bit better.
And I'll ask you this question, although I mean Prof. Vardis could also answer this. Patients with Guillain-Barré, are they able to take the vaccine, or because
in the active form, or active Guillain-Barré right now?
Yeah,
I don't think we'd really administer a vaccination to somebody who has Guillain-Barré now because of the, once again, what side effects would we be having from the disease and what side effects would we be having from the vaccine. Okay. But post the active phase of the Guillain-Barré, when the patient's recovered and they're off their Polygam, which is one of the treatments, or they're not getting the PLEX therapy, then there shouldn't be any contraindication there. But Prof. Vardis can jump in and maybe give her view.
I think you covered it. We agree, and the current recommendation is you don't vaccinate while they're in their active phase for any vaccine, and you would wait until after they recover. Yeah.
Well, thank you for that. All right, Dr. Khan, we'll give you a bit of a break for now. I think we're going to move on to Dr. Motekef. Dr. Motekef, I know you have an interest in anosmia as well. So I'm going to pose these questions to you because I think between you and me, we'll be able to come up with a few answers. We're ready to go, Dr. Motekef.
Yeah, I'm trying to unmute.
You're unmuted.
I'm unmuted. Okay.
So there's quite a few questions regarding the smell. I think this anosmia is really something that has taken hold within our population. So I'm going to read the questions to you, and I think we can do them all at one go. So the first one is from Hendrik Vogel, and he says, my 44-year-old son, about 8 months post-COVID, has persistent offensive cacosmia and cacogeusia. So he'd like to hear from us what our views about the cause and the prognosis. So post-COVID, 8 months.
Sorry, how old was the patient? I missed that.
44 years old.
44 years old. Yeah. I think one I would ask is that did it start at exactly the same time as COVID? Because one always have to look at possibility of the other causes as well. Have they tested all? I mean, did it start at about the same time? So then we can think that is definitely coming from the COVID.
Yeah, there's no, so unfortunately, we're not going to be able to get any more information. That was all the information we have.
So I would actually approach a pair because majority of the smell anosmia and they should actually recover majority, and of course we've got a few that are not. So in this scenario, I would still go and do a full investigation in terms of make sure that there is no other possible causes. And once that is done, then the only way we actually is the olfactory training. They have definitely published articles that they've shown that this olfactory training is quite beneficial. So I would definitely recommend that. And they can actually also use, there is a sort of protocol that people can also use it at home. So they can slowly to increase their smell. So if the other possible causes have been excluded, the only management and treatment would be try to olfactory training.
And I think, I'm not sure if you agree with me, but most of this is probably neurological more than actually conductive in terms of the smell and taste. Would there be any role, because the current belief is that it may be a orbitofrontal cortex involvement in doing an MRI or functional MRI in these patients? Would you suggest such a thing?
You know, I personally think if a patient continue having it, the anosmia, I would do a full investigations.
Okay.
And definitely I would do it. And regarding what you said about to be neuropathic as opposed to just any conductive, there is quite a wide range of that, they said. I mean, initially last year there was article came out and they were looking and they did a full CT scan and they saw that the patients did have no swelling in olfactory area at all. Yes. But then later on, more recent one, they've got now articles that they actually could see that there is some inflammation. So at the end, the pathogenesis of anosmia is actually, it's not just one. It is, there are a few reasons that they're getting it. And then it depends on the cause that they have. Most likely that some recover quickly, in fact majority, and there's some that they remain. But I still think that it's very important to do a full investigation.
Yeah, and I think also referral to a specialist. I think a neurotologist or neuro-ENT would probably be the right person to investigate these patients further, specifically if it's gone past, say, a month and yes, they still have neurological disturbances in smell, taste, hearing, balance. Thank you for that, Dr. Motekef. I think that was an excellent answer. Now it is now 10 to 9 and we were supposed to wrap it up. Marika, we still have a few questions. What is the way forward? Do we pose these questions or perhaps we can get the panelists to answer them at a later stage?
Yes, it's up to you, Prof. Maharaj. I don't know if the panel wants to take a few more questions. I'm sure, everybody's still, the majority of our attendees are still logged on. So if you want to take 2 or 3 more questions, we can do that. Ultimately, we can also ask the IT team from Lancet to just pose those questions onto the website itself. And then just a reminder that the link to that website will be emailed to everybody to be able to utilize that platform and obtain the points 3 to 5 days after this event. But if you feel comfortable in attending to 2 to 3 questions more, we can do so.
Yeah, so I see there's far more than 2 to 3 questions, and most of our panelists have given us their time from about 5:30, 6 o'clock today. So I know there's a lot of interest, but I think as respect to the panelists, I think we should end this discussion now. And also, we don't want to rush through the questions. I think it's also important for our panelists to have a look at the questions and answer them in their time and provide knowledge that is up to date as well as appropriate. So I think we're gonna call it a night. I think it's been a long day and we've been preparing for a long time.
Yes.
These are not questions that we can, they're not yes/no questions, you know.
So perhaps we can ask Robin to help, then we can add them to the MCQs that will be available on the website. Yeah, so we will add them to those.
I think that will be a good idea. I'd like to thank the audience for their active involvement and for the many questions that we've been posed. I think there's been good audience participation, and to the panelists, I think you've been absolutely amazing. Every single talk has been well executed, well researched, and well delivered. It's been an honor and a privilege to chair this, and thank you for affording me the opportunity. So I'd like to wish everybody a good evening, and I'm going to hand you back over to Mareka to do the conclusion.
Thank you, Prof. Maharaj. Yes, thank you for chairing the evening. And to all our panelists, a humble, big thank you from our side, from our company, Rightsa Healthcare, and I think I speak on behalf of Lancet's IT team and everybody as well in thanking you for making this possible. We wouldn't be able to do this event if it wasn't for you. Thank you to all the attendees as well. If there's any topics of interest that you want to hear more of or any new topics, please feel free to email either myself or Robin from the Lancet team. We will post our email addresses in this chat box for you to utilize, and then we will also make sure that it is on the website as well after this event. Just make sure that you enter the link in the chat box to complete the attendance register as well, please. That will generate your points for this evening, and then your certificate will be emailed to you. Thank you to everybody, and I think if we conclude it, then we say good night.